Stakeholder Presentation for Advanced Leadership for Contemporary Nursing by Gail Jester. Description of the organizational change and the problem that has been identified is that post-traumatic stress disorder has been identified in patients in the ICU, and it can affect them and their loved ones. Post-traumatic stress is mainly thought of in context with people who have experienced warfare, traumatic events, or a catastrophe, and not in conjunction with a stay in the intensive care unit. A recent study conducted by Johns Hopkins University showed that nearly 1/4 of survivors of an ICU stay experience PTSD. The number is staggering and should become common knowledge for the bedside ICU caregiver, so that they can be aware and intervene if at all possible. There is a growing body of evidence that shows that patients and their loved ones can experience PTSD after a stay in the ICU, and there are more than 5 million ICU stays each year in the U.S. Second, the increased sedation levels leads to poor outcomes in the ICU. Many studies in recent years have shown that increased sedation in the intensive care unit setting leads to poor outcomes for the patients we serve. These poor outcomes include cognitive deficits, physical limitations, and mental health related difficulties. And finally, many ICU patients experience delirium in the ICU. It has been demonstrated that most ICU patients experience episodes of delirium. Delirium and coma have been recognized to be very common and experienced by up to 80% of mechanically ventilated patients. The disturbance develops over a short period of time, usually hours to days, and tends to fluctuate during the course of the day. The plan for the quality improvement is to implement an evidence-based bundle of interventions. This is called the ABCDEF bundle and consists of assessing and preventing and managing pain, conducting both a spontaneous awakening trial and a spontaneous breathing trial daily, managing our choice of analgesia and sedation and avoiding benzodiazepines, assessing for delirium and helping to prevent and manage ICU-acquired delirium, implementing an early mobility and exercise program, and encouraging family engagement and empowerment. There is a growing body of evidence that says that by implementing the bundle of interventions, we can limit the effects of a long intensive care unit stay for these patients. By implementing this bundle, the organization is incorporating the latest evidence-based practices in regards to caring for the critically ill patient. The quality of care provided increases with the use of this bundle and decreases negative consequences of an ICU stay. And by implementing every part of the bundle, the quality of care improves the eventual outcome for the patient. All individualized components of the bundle are evidence-based and can help standardize communication, improve interdisciplinary patient care, reduce mortality, and improve long-term cognitive and functional outcomes. The quality improvement model that we're going to use is the FOCUS PDCA. The PDCA is to plan, identify a gap in knowledge. The identified gap in knowledge is that the bedside nurse does not know the current research in regards to best practices put in place to limit the patient's long-term cognitive, mental, and physical disabilities as a result of their ICU stay. Do is determine the tools to be used in a gap analysis. We're going to use debriefing, case studies with group discussion, observation, and audits to implement these tools in regards to the gap in knowledge that exists. Check, we're going to evaluate the results, so we're going to determine where the gap in knowledge exists and concentrate our education offerings in that gap in knowledge. And finally, act, we're going to take the learned information about the gap in knowledge and apply it directly to the educational needs of the unit through classes, daily huddles, and online learning assignments. There are many stakeholders involved, both internal and external. Internal stakeholders include patients, families, the nurse, physicians, respiratory and physical therapy departments. The work environment has been shown to play a role in respect to sustaining and enhancing the effects of a quality initiative or project. Primary stakeholder is the patient themselves and must be considered in all aspects of care decisions. They are ultimately the recipient of the care and will reap the benefits of being treated with the best evidence-based practice that is available. Poor care, for instance, the heavy use of benzos to sedate a mechanically ventilated patient has been shown to lead to more delirium and cognitive deficits after an ICU stay. External stakeholders would be people like hospital leaderships, the CMO, CEO, the hospital board of directors, insurance companies, and licensing agencies such as the Joint Commission and CMS. The benefits of the organizational change are that we're going to decrease the pain experienced by patients in the ICU by assessing, treating, and managing the pain early. We're going to assess spontaneous awakening and spontaneous breathing trials daily, every 24 hours, to determine the patient's readiness for weaning from the ventilator. We are going to avoid the use of benzos for sedation unless it's indicated for the patient's condition, and the goal is to decrease benzodiazepine use for all patients. It's been shown that excessive use of sedation or benzodiazepines in the patient that require mechanical ventilation causes longer stays in the ICU, higher costs for healthcare, and long-term negative consequences for the patient. Long-term morbidity, long-term cognitive impairment, and hospitalization associated disability are a common occurrence in survivors of critical illness. By reducing the use of benzodiazepines in mechanically ventilated patients, the organization could reduce the number of patients who experience delirium, PTSD. They can decrease their length of stay, thereby reducing cost of care, decrease the number of patients that face long-term cognitive consequences from being on these medications, and decrease mortality in this population of patients. Next, we're going to assess for, manage, and prevent ICU delirium by completing a CAM ICU delirium assessment each shift. And if the patient screens in positive and is on a benzodiazepine, then a rate reduction or a discontinuance of the medication must occur within 1 hour of identification of delirium. Next, we're going to provide early mobility for every patient. We're going to assess readiness for mobility with the goal of providing the tolerated level of mobility each shift. And we're going to empower our families to be engaged in the care provided to their loved one and arrange a family meeting within 72 hours of admission to the ICU. Risks of non-implementation for patients will be the struggle to recover post an ICU stay. Quality of life related to health has been shown to be decreased in patients after a stay in the ICU, but this also applies to spouses of patients, and high rates of anxiety and depression have also been reported. Patients experience hallucinations, delusions, and paranoia, and this is very common. Another study of anxiety and depression in recovering critical care patients found that high incidence of psychological problems were associated with an adverse social and economic status. Next, physical, cognitive, and psychological problems, including anxiety and depression, can be experienced. Defects in executive function have been demonstrated in general ICU patients at 3, 6, and 9 months after discharge from the ICU. And also a recent study in the review of long-term outcomes of acute lung injury found that physical and cognitive impairments could still be present 5 years after recovery. Next, the patient could suffer from a loss of gross muscle mass and weaknesses, which takes months to recover. We know that the first step in helping patients to recover from such devastating illnesses is to recognize those who have the greatest need and target interventions, such as early mobility programs. Patients can suffer from post-traumatic stress disorder. Research now suggests that there are interventions that can accelerate physical recovery and reduce the incidence of psychological problems such as anxiety, depression, and PTSD. And finally, the patient can experience cognitive deficits that affect memory. Cognitive rehabilitation is still in its infancy. However, in European countries, ICU diaries written by nurses have been used as a way to help patients to come to terms with their illnesses. The diaries consist of written text and pictures of the patients as they have changes in their conditions. And some studies have shown that the diaries bring a sense of comfort and encouragement and help provide hope to the patient. The ethical issues that go along with patient care technology in the ICU, lighter sedation implies that patients are more aware. The positive aspect of this could be that the patient is able to participate in care like the early mobility program. The negative aspect is that the patient may be aware of impending death. Next, advances in technology mean prolonging lives of patients, and sometimes there is a question of futility of care. Often, the intensive care unit team is faced with the ethical dilemma of deciding whether it's in the patient's best interests to withhold or withdraw treatment. Advances in nursing expertise, treatments, and technology have increased the number of patients in intensive care units who receive life-sustaining therapies, even though their prognosis is poor and the situation may become futile. Communication issues should also be emphasized, and it's been shown that communication issues involve the dying patient's family, and good communication has been shown to be the most important predictor of the quality of end-of-life care given by family members. The importance of the nurse's engagement and involvement in conversations with families cannot be overestimated. Next, the role of nursing leadership. Nursing leadership needs to advocate for the change within the organization. Quality improvement projects require a supportive environment in order to become successful. And effective change requires innovation, team culture, and professional commitment to achieve improvements in the quality of care. The nursing leadership is also going to support the bedside staff in implementing these interventions. This support will include things such as additional staff and equipment needs, encouragement and acknowledgement of successes in the implementation process. The nursing leadership will also disseminate the plan to the other leadership stakeholders, including the CEO, CMO, and board of directors. And finally, the nursing leadership is going to support the team collaboratively. Collaborative leadership in the role of the clinical nurse leader is essential to adoption of new quality improvement practices. And leadership is an important aspect of successful implementation of evidence-based practices.